Well, good afternoon, everybody. Brenda, I'm not sure if I can still hear you, but I think we're ready to get started. Is that right?
Yes, I'm right here. I can
Great.
hear you.
And did you want to say anything before I jump into the content?
Oh, go right ahead.
Okay, great. Well, thank you all for joining this session today. We got about an hour of your time, and there's over 80 people here signed in, and so thank you all for your time. My name is Ryan Price. I am the area director for the states of Oregon and Idaho for the American Foundation for Suicide Prevention. And this is a presentation, and the key word on the screen here, it's an introduction. So we're going to go through about 50 slides here in the next like 45 minutes or so. We should have some time for questions. So if you have questions throughout the presentation, you can drop them into the questions bar of your participant controls. But keep in mind that this is an introduction, and that the things I say, you may have a tendency to think, well, yeah, that's easier said than done. And it's true because this is an introduction. Now, I know all of you are part of schools or businesses or different areas where you have purchased into or utilized the services of Reliant Behavioral Health for your EAP. And so we're going to talk a little bit about that part of it here. Um, Towards the end about what RBH offers, but I also wanted to make this presentation available to you. If you have a group of people at a workplace or a school, something like that, and you would be interested in having us come in to bring this presentation, it is free, and we can put our contact information up towards the end. And so if you were interested in having this brought to you for a larger group or a small group, even at your office or school, feel free to reach out. So without further ado, I'm going to jump into the content. We do know that suicide is a health issue, but it's also a complicated health issue. It's complex. And despite its complexity, though, we can save lives from suicide. So when we talk about suicide in this presentation, we're going to go over four main areas of the field of work. First is the scope of the problem of suicide. The second is what we've learned from research. The third, we're going to talk about some prevention strategies. And then the fourth and final one, we're going to talk about some real practical strategies and what you can do. But before we jump into the research area, I want to just talk about the way that we use language when talking about suicide. How we talk about suicide really matters. And there's some things that there are popular ways to discuss or mention suicide that we're trying to avoid as we move forward and create a culture that's smart about mental health. So the first is this term committed suicide. It's something that's been that we've used as a culture for a long time, but that phrase committed can imply that something there was a choice and that we did something bad. So people commit adultery or commit a felony. So we're trying to change the culture and use phrases like died by suicide, ended his or her own life, or killed his or her or themselves. Also, when it comes to suicide attempts, just sort of the way that our language works, we have a tendency to say things like a failed or successful suicide attempt. There's really no such thing as that. Either someone survived a suicide attempt or had a suicide attempt, or they died by suicide. So we don't ever want to, convey any sort of positive connotation as something being successful when we're talking about a suicide attempt. So either someone died by suicide or they had a suicide attempt and survived. And so those are just some little things, and you may hear me say phrases that you aren't familiar with, and those are some of the reasons why. So the first section is the scope of the problem of suicide. The World Health Organization estimates that over 800,000 people die by suicide each year across the globe. And we think that's a pretty conservative estimate because there are a lot of countries that do not accurately report suicide deaths. That works out to someone dying by suicide about every 40 seconds. In the United States, suicide is the 10th overall leading cause. And our data is a couple of years old, and it takes the Centers for Disease Control a couple of years to get their data up to date. So the most current data that's available is from 2017. And in the United States, 47,173 people died by suicide. Now, this does not include deaths that were ruled overdoses, but may have been intentional. So even with this number, there's a good chance that the people who made an intentional act to take their life, not all of them are recorded because some overdoses are coded as overdoses and not suicide. So that's still a staggering number of people dying by suicide in our country. Also, we know for every person that dies by suicide, it's estimated that an additional 25 other people will survive a suicide attempt. So that means that in any given year, there's about 1 million people in the United States who have survived a suicide attempt. We also know that the impact of suicide also has a ripple effect in our communities, workplaces, and to individuals. It's estimated that most people in the United States will be impacted by a suicide at some point during their life. It may be that they're worried about someone, that they've lost someone they know or love or work with, or that they struggle themselves. But we do know that most people will be impacted by suicide in one way or another. The CDC also estimates that there is an economic impact due to primarily lost wages and productivity to suicide. They put that figure at about $69 billion per year. So it's lost productivity as well as healthcare costs in the United States. So here's a good place to pause to see if there's any questions. I only see one technical question about the webinar, so I'm just going to pause for just a moment to see if there's any questions about the scope of suicide before we move on. And if you think of a question later, we should have some time at the end for questions on the scope as well. All right, not seeing any questions, I'm going to go ahead and move forward. It's really only been the past couple of decades that researchers have been doing research into suicide prevention and mental health. And one of the big questions that research seeks to answer is why, this question of why do people take their own lives? And what we've learned is that this sentence that is one of the ones that's like, well, yeah, easier said than done. There's no single cause, but there are multiple intersecting factors that converge at a time that create an increased risk for people. So the short answer to why is it's complicated, and we're going to talk about some of the ways that that we can sort of break down this complication and the things that we've learned from research so far. We do know that the majority of people who die by suicide have a diagnosable mental health contributing at the time of their death. This may or may not be adequately treated, but we know that mental health conditions like depression and bipolar are closely linked to people dying by suicide. Most people who experience mental health conditions like depression or bipolar do not go on to die by suicide. So that's not the whole picture. Research has also shown that there are physical differences in the brains of people who die by suicide versus the brains of people who die by other causes of death. These are related, specifically in areas related to the stress response and impulse control. So time, and we'll talk about this in a future slide, but time is a critical prevention strategy. And so if you can, picture this, that people that die by suicide, their brains are physically different than people that die by other methods. And so this idea of time is really, really important, and it'll come into play here in the presentation in a little bit. We don't yet know from research, is there a causal effect? Is this something that people are born with? That's one area of research that we still need to investigate further. We also know a little bit about the perspective of people who are suicidal, that they are ambivalent about taking their life, that there's a part of them that wants to live, but there's also a part of them that wants to die. And so for a long-term prevention strategy in a clinical setting, providers will often work with patients who are suicidal to try to help them develop tools that they can use to engage the part of themselves that wants to live and put down the part of themselves that wants to die, or come up with a plan, a safety plan, as it were, for when a person is feeling suicidal. So the perspective of a suicidal person is that a crisis point has been reached. They're in desperate they're desperate to escape the pain that they're in, and their thinking becomes limited. This really intense tunnel vision sets in, where other options like getting help or reaching out to someone, they seem completely out of the question. So if you're in a place where you're comfortable doing this, you can close your eyes or just look down at your desk for a moment. But if you can, try and imagine the time in your life when the physical pain that you're that the where excuse me try and imagine a time in your life where your physical pain was at its peak. For some people, it's the birth of a child or a car accident, or that may be a broken bone or something like that. But at a time when you had your most intense physical pain, and try and picture at that moment if you would have been able to give somebody clear and accurate directions to your house. The majority of us, for the majority of us, the answer is no. That during our most intense physical pain, our thinking becomes limited to just stopping the pain. And that's sort of a clumsy example of the perspective of a person who's suicidal, is that they're in crisis, their thinking is limited, and other options are totally unavailable. And again, these crisis times, time is a critical prevention strategy because they're not permanent. They don't last forever. They tend to go away given time. So now research, we've also learned to have a better idea about who is at risk. So we're going to talk about risk factors now. And if you can think of these 3 risk factors as being similar to risk factors for other causes of death like cancer or heart disease, where we know there are certain things that can put a person at increased risk of getting cancer at the time in their life, but it doesn't necessarily mean that everybody with risk factors is going to get cancer. So for example, you might have a family history of cancer. You might have been a tobacco user for a long time, and you might lead a sedentary lifestyle where you don't eat really healthy. Those are some pretty serious risk factors for cancer, but it doesn't mean that you're going to get cancer. The same is true for risk factors for suicide. We kind of break them down into these 3 main categories of health, historical, and environmental risk factors. So we'll go through each one a little bit. The first are health factors, and the most commonly associated health factor with death by suicide is mental health factors. So things like depression or psychosis, anxiety disorders, and substance abuse disorders. These are all things that are closely linked to people who are suicidal or people who die by suicide. But also physical health factors, things like serious or chronic health conditions, major head injuries, or chronic pain. These can also put a person at increased risk for suicide. Historical factors are things that have happened to a person at some point in their life, in their history. So a family history of suicide, a family history of mental health conditions, also a previous suicide attempts can put a person at increased risk. This is one that we see often in our work, where people are committing to breaking the cycle of suicide in their lives. There's a volunteer we have down in Eugene who her grandfather and her father and her brother all died by suicide. They had mental health conditions, bipolar being the primary one. And this volunteer, she also struggles or suffers with thoughts of suicide and has bipolar, but she's made a commitment to stay and break that family history. And also previous suicide attempts. While it does put a person at increased risk for suicide, it doesn't necessarily mean because a person has survived an attempt that they will go on to die by suicide. Rather, just puts a person at increased risk. Okay. So I think I might, oh, there, sorry, I skipped a slide. The last category of risk factors are environmental factors. So these are things that a person has access to in their environment or has seen. So access to lethal means or having easy access to something that could become lethal is a risk factor. Prolonged stress and stressful life events, also being exposed to or seeing graphic depictions of suicide can put a person at increased risk. So things like if there's a suicide at a workplace, handling it in an effective way so that the people who were there or who knew the person limits their risk factors. Also, TV and movies can be a risk factor because often they will have graphic or glamorized depictions of suicide. So these are important things to know that they really do put a person at increased risk. So the risk factors, often these are things that are underneath the surface. And so we might see somebody die by suicide that is, an actor or someone famous or someone that we know. We may see them at the same time they die by suicide going through a difficult breakup or a divorce. And it would be easy for us, and as humans, we generally want to have a cause and effect type of response to things. It would be easy for us to say that difficult relationship breakup caused a person to die by suicide. And while things like that, like job losses and breakups, they are known to potentially play a precipitating role, they're not thought to cause somebody to die by suicide. And so what we may not know is that a person who died may have a genetic risk for suicide, that maybe they had depression that wasn't treated, and that they were experiencing prolonged stress at work, which led them to be drinking more than usual, which made their depression worse, which impacted their performance at work. All of those things may be underneath the surface that we don't really know that could have contributed to the person dying by suicide. So while those factors, the things that happen, those really tragic things like breakups or job losses can play a precipitating role, they're not thought to cause someone to die by suicide in themselves. So moving forward with the importance of future research, the American Foundation for Suicide Prevention is the largest private funder of suicide prevention research. And we also work with the federal government to try and increase funding for suicide prevention research. But we're going to be looking at things like biomarkers, like is there something in a person's blood that we can learn about that might indicate that they're at increased risk? Are there better interventions that we can help implement in different settings to save lives? Also, are there different and better therapies and medication to treat people with mental health conditions? Those are all some of the really important questions and challenges we're going to be looking at when it comes to future research here. So I am gonna just pause here. It's a great time for questions on the research section, and I'm having trouble seeing. I see one question about vets, and I'm just having trouble scrolling through. I don't see the whole question, so I don't know if you can help me out there as we wait for other questions to come in.
Are you looking at the one about vets?
Yes, I can't see the whole question.
Okay, I can read it out if that would be helpful.
Sure, yeah.
Okay, is it possible that the reason more vets are prone to suicide is because there are differing stress responses? Oh, it's not letting me read it either.
Yeah. Well,
Oh no. Sorry.
We'll work out those questions. We'll try and figure that out as we go. But I do see another question. What is the male/female breakout of suicides? And this goes back to the scope of suicide. Females on average tend to attempt suicide at a rate about 3 to 4 times higher than males. But males account for about 75% of the deaths by suicide. So men and boys, people that identify as men and boys, take their life 3 times more frequently than women and girls do. Okay, still struggling to see that question about vets, so I'm going to move on to the prevention section here. So there are some key prevention strategies when it comes to saving lives from suicide. So just like there are risk factors for suicide, there are also protective factors. These include things like taking care of your mental health, having a family and community support, also problem-solving skills, and cultural or religious beliefs that discourage suicidal actions or behavior. Now, the cultural and religious beliefs, I know that that one can be a little bit tricky because there are some prominent faith groups that have not always handled mental health and suicide adequately. And so there is a chance that in some settings that that cultural or religious beliefs could become environmental risk factors for suicide. But those that religious beliefs and cultural beliefs that encourage help seeking and getting help, those can be protective factors for suicide. Since mental health conditions like depression and anxiety, bipolar, are most closely linked with suicide, taking care of mental health is such an important ingredient for preventing suicide. Right now, in our culture, only 2 in 5 people with a diagnosable mental health condition will actually go and seek treatment. So one of the things we can all do is if we sense that something's wrong in our own life, in our own mental health, that we can go and get help, that we can talk to people about what's going on, because right now, not enough people with a diagnosable mental health condition go to seek help. So we really need to develop and to build a culture where everybody knows that it's smart to take care of your mental health. And we do a public opinion poll, and over 85% of Americans view in these public opinion surveys, they view mental health and physical health as being one and the same. And so sometimes the lack of help seeking on our own behalf can kind of be a self stigma. Like we kind of think we can do it on our own, but we maybe know there's a problem. So really important for all of us to get help and seek help when we think we might need it. So being proactive about your mental health, the way that you can do that is to just make your mental health a priority. Go and see a doctor or mental health professional and get an evaluation. One thing that is often overlooked when it comes to seeking help for mental health is to talk about treatment options and find something that works best for you. There's lots of different treatment options available, and not everyone is going to be comfortable with taking medication. There's also, various different kinds of therapy models, and therapists and mental psychologists, mental health professionals. It's a very personal kind of thing. So find a treatment plan that works best for you. I know I had an experience with a doctor who at one point gave me a short 5-question survey, which is really good. It's a depression screening that helps to indicate depression and mental health conditions. And I did the thing. The doctor came back and said, "Oh, it looks like you rated really high for depression." He gave me a piece of paper that was sort of like a menu of medication that had the various different side effects. And he said, "So which medication do you want to take?" And for me, it was kind of like, whoa, like pump the brakes a little bit. Can we talk about what I can do maybe first? Or do I have to take medication? Like, what are my options here? And it's the same way, with treating any other kind of health condition. If you rate high for like pre-diabetes or something like that, you might talk to your doctor about, maybe are there some things I can do before I have to start doing insulin, or before I need to make some of these really serious changes. Like maybe I can, change my diet for a little bit, or maybe I can exercise more. It's really important when it comes to seeking or help for our mental health that we talk about treatment options that we're comfortable, and find something that works best for you. The great thing about mental health is there's something called mental health parity that the federal government, it's a law that insurance plans are required to cover mental health services at the same level as they cover physical health services. And for each of you on the line, RBH has a suite of counseling services that we're going to talk about a little bit later that really decrease the barriers to help seeking, I think, for you, your employees, and other members. So the great thing, just like other major health conditions, there are self-care strategies that all of us can employ to help take care of our mental health. So exercising regularly, eating a healthy diet, sleeping long enough and regularly enough, and also managing stress in a positive and effective way are all great strategies to take care of our own mental health. And I know, for me, what I've found works best is, and what is sort of the trigger for my own self-care is exercise. You can't see it, but I've got like a fitness tracker watch on, and I know that if I'm not wearing that, I'm probably not moving around or exercising enough, which means my diet probably isn't as good. I'm not sleeping as well. I'm probably drinking too much, which makes my stress worse and makes it harder to eat healthy and harder to exercise. And so, taking care of your own self, it looks different for everybody, but I know, like, what I found for me is that, this exercise or just regular movement is sort of a trigger point to help me stay on the right path. And so taking care of your mental health looks a lot different for everybody, but these four strategies are important components of taking care of your own mental health. Also, a key prevention strategy, and we talked about the fact that losing someone to suicide or a family history of suicide puts a person at increased risk. We need to have better support for people who have lost loved ones to suicide or those with lived experience that struggle with thoughts of suicide. So one great way we can offer support is by both being there to talk with people and support them through it, but also to be familiar with the resources that are available and encourage people to seek help if they need it. When it comes to saving lives from suicide when a person's at risk, the most important thing we can do is put time and distance between a suicidal person and the method that they're thinking of using to take their own life. So this is called lethal means restriction. And so, I mentioned that the brains of people who die by suicide are different than those that die by other methods. So this time, when you put time and distance between the method a person's thinking about and the person, often we will save their life and we will be able to link them into the help that they need. Because limiting access to lethal means or to things that could become lethal does prevent suicide. So limiting access to lethal means could look like a lot of different things. It could be installing a carbon monoxide sensor in cars that would shut it off if levels got too high. It could be putting fencing or barriers on bridges. Also, blister packaging or locking medication at a time of increased risk can be great strategies. And also, having access to firearms, firearms are the most lethal method used for people that die by suicide. And so having a way to put time and distance from a person and a firearm, if that's what they're thinking about, is a great way to save lives. And it doesn't have to be permanent. It doesn't have to be forever. But during times of increased risk, limiting access to lethal means is a great way to save lives. And so often people will think, why should we put a fence on this bridge? Because if someone's suicidal, they're just going to find another method. And the truth is that couldn't be further from the truth. That there's at least 4 major studies that show that when we temporarily limit the access to something that could become lethal, that a person thinking about using to take their own life, that they will not find another method, and will allow time for the crisis to subside and to get them the help that they need. And so this is a really important factor that putting time and distance between a person who's suicidal and the method that they're thinking about absolutely saves lives. So gonna pause here for some additional questions to see if there are any. I'm gonna try one more time to get this question about vets open up and see if there's any more. I don't see any more questions. Oh, maybe I can. Nope, I don't see the whole question. So I'm really sorry about that. Actually, maybe I do. Is it possible that for the reason more vets are prone to suicide is because they have differing stress responses based on their experience during tours? Okay, I think that's the whole question. And so the short answer is yes. That the things that our armed service veterans go through while deployed and in basic training can change the way a person thinks. But again, just like the other risk factors in one of the first slides, is that it's complicated. The truth is that about 20 armed service veterans take their life in the United States each day, and so the risk factors are there are some that are unique to armed service veterans, and there are others that are similar. But there are a lot of additional stressors that our veterans face, like being away from family and friends, having to move unexpectedly, having to make difficult decisions, having to be gone for long periods of time, having access to firearms. There are also there are other risk factors that do tend to put our veterans at increased risk. So that's a great question. Thank you. Moving on, I don't see any additional questions, so I'm going to move on to this next phase of what we all can do. The most important thing that we can all do to save lives from suicide is have a conversation. To be willing to reach out if we're worried about ourselves, or to reach out if we're worried about someone else. So the kind of three-pronged approach that we suggest is to watch for warning signs, to reach out, and then to seek help or to get a person to help. So warning signs are different than risk factors. Risk factors are things in a person's life we may or may not see that put them at increased risk. Warning signs are just that. They're like danger, Will Robinson. We got a problem. We need to check this out. They are warning signs that we can observe that indicate that a person might be desperate or even thinking about suicide. So in these three main categories of talk, behavior, and mood. So the first category is talk. That most people who die by suicide will say at one point in the things they say and they verbalize that they're thinking about suicide. So they may say that they're thinking about ending their lives, or that they have no reason to live. They might tell you that they're a burden to others, or they're an unbearable pain. Anything that might seem to indicate a person's thinking about suicide, what we suggest is to take it seriously every single time. Now, this can be challenging with young people because we may view it as attention seeking, and it may be that, but it may not be that also. And so if a person indicates these things, it may come off as a joke. They may say they aren't really serious, but what's really important is that if someone says something that seems to indicate that they're thinking about suicide, we have to take it seriously every single time. Now, behaviors, these are things that are different from a person's regular behavior, atypical, or they last longer than you might expect, or they're more intense than you might expect for a person. That's something that just is different for them. So an increased use of alcohol or drugs, issues with sleep when there weren't any before, withdrawing from activities that a person normally is involved with or enjoys, and giving away possessions. Also, things like looking for a way to kill themselves online. Newsflash: no one's doing a report on that unless you're a scientist, in which case you won't be Googling that. So these are all things that in a person's behavior that might indicate that they're at an increased risk. For me, people that know me pretty well know I'm fairly even. My behavior isn't super reckless, and so if I bought a motorcycle and started doing things that were really reckless, the people that know me would know that that's just not like him. So something might be going on. It would be a pretty good indicator that there was something off with me, and it would be a sure sign that someone should reach out. But also, things like issues with sleep. Some people have insomnia. Some people just have issues with sleep. So if it comes, goes in short periods of time, and that's normal for a person, that may not indicate anything is wrong. But when someone has issues with sleep that they don't normally do, they're sleeping too much or sleeping way too little, they can't sleep, that would be a sure sign to reach out. The same is true for moods. All of the moods that you see on the screen now, depression, apathy, humiliation, irritability, these are all things that you might expect from just being a human. You might experience these, and most people we know will experience these things at short periods or different periods of time. But when they're when they're more intense, when they're atypical, when they last longer than they should, or they're different, that's a sure sign to reach out. The important part is, and we kind of breeze through these warning signs. What we want people to understand is to just trust your gut. Maybe you don't remember all the warning signs or the risk factors. You're not sure what's going on, but to just trust your gut and assume that you're the only person who's going to reach out to them. Oftentimes, we will talk to each other about the people that we're worried about. We will, say, oh, I'm really worried about so and so because of these things. The important thing is that if something seems off about a person, they're just, even if you can't quite put your finger on it, it's a really important thing to trust your gut and assume that you're going to be the only person that reaches out. So how do you reach out? The first thing, talk to them in private. This is not something you call a person out in a meeting. You don't say, hey, we're really worried about you. Not a good place to do that. But also listen to their story and express concern and caring. One thing that's a big myth about suicide is we want people to ask directly about suicidal thoughts in a way that does not imply judgment. So asking in a way like, are you thinking of ending your life, or have things gotten so bad you're thinking of suicide? Those are ways that you can get an answer to a question without expressing judgment. So the worst way to ask this question is, you're not thinking of killing yourself, are you? Or things can't be that bad that you're thinking about suicide, right? That sort of approach of, judging a person based on the situation that you can see is really not helpful. So a better question is, are you thinking of killing yourself? It's direct, and it's also doesn't implore any judgment or anything like that. And one myth about this question is that if you ask a person if they're thinking of suicide and they are not, your asking the question will not plant the idea in their mind. If they're not thinking about it, they're not going to if you ask the question. So that's a myth about suicide that has been proven through scientific studies several times over. And then also encourage people to seek mental health services. Sometimes it can be hard to have this conversation because we want to jump in and sort of like offer advice or trying to help people fix things. But this idea of expressing concern and caring really goes a long way. And so sometimes it can be helpful to just sort of, after a person kind of tells you what's going on, to just reiterate what you heard. So that way the person understands, hey, you were listening to me. I understand you. I'm not judging you. And saying things also like, oh, that must be really difficult for you. Is there anything I can do? Like those kinds of things can go a long way. But there are some things we can all avoid doing during this conversation. And I think that, if any of you are managers or work with managers, these are all things too that, regardless of a risky situation like someone thinking about suicide, but if you have an employee or someone you work with or a volunteer that is a part of your group, these are also really important things to do during those conversations also. But when you do reach out to someone that you're worried about, you've trusted your gut and you're going to reach out, you ask them about suicide, during this conversation, you want to avoid minimizing their feelings, saying things like, oh, it can't be that bad, or things will get better, just give it time. Those are all things that might be true, but are not helpful at that time. Also, avoid trying to convince them that life is worth living. In this moment of a person sort of talking about what's going on with their lives, if they say they're thinking about suicide, it's really important to just validate those thoughts and express concern and caring. It's not really a conversation to have to try and convince them that life is worth living, because sometimes it's tempting to do that, because if we're not the ones that are suicidal, we're thinking clearly. We can think like, well, your kids, like, what are you gonna, like, what would they do without you? But in a person who's suicidal, in their mind, they might have a very genuine belief that their spouse or children or their family or friends would legitimately be better off if they were gone. And so, this trying to convince them that life is worth living by saying, well, everybody would miss you, that's not a helpful conversation if a person's at risk for suicide, because they're not thinking clearly generally. Also, avoid advice to fix, a problem if there is a sort of tangible problem we can fix, or feel like we can fix. Right then in this moment, is the most important thing we can do is listen. And so offering advice to fix it, trying to convince them that life is worth living, and also minimizing a person's feelings tend to be not helpful. And if a person says, yes, I'm thinking about suicide, or you think that they might make an attempt at their life soon, stay with them. The only caveat to this is that if staying with them puts you at risk or puts you in danger, don't stay with them and call 911. So if a person's not going to put you in danger, stay with them, help them secure lethal means, or remove them from the environment. Go take a walk, take a drive, go to the mall, go see a movie, but get them out, get them into an environment, or remove things from their environment that could become lethal. And also escort them to mental health services. And this could look like, mental health services could look like a lot of different things. So I'm going to leave this slide up for just a few minutes, and I would just ask all 107 of you on the webinar now to just pull out your phones and plug these phone numbers and this text number in as a contact. The National Suicide Prevention Lifeline is a very remarkable service that 1-800-273-8255 will work from anywhere in the country. And when you call that, you will be connected to somebody who is in a local crisis line. So there's a network of crisis lines who are certified to take these suicide prevention lifeline calls. And so, for example, I'm in the Portland area, and so if I call the 1-800-273-8255, it's going to route me to Lines for Life, which is the call center or the lifeline contractor in the Portland area. And so they're going to be able to offer consistent service. They're master's level clinicians or trained volunteers who are supervised by master's level clinicians. And they'll also be able to give you local resources. And there's lots of different local crisis lines, like Multnomah County in Portland's got a crisis line. Marion County in Salem also does. But the National Suicide Prevention Lifeline will work from anywhere. And also, the crisis text line, it's a little confusing. The number you text is 741-741, and you just text the word talk. So if you open up a text, the number it's going to is 741-741. Just text talk to that number and you'll get started with the conversation. The crisis text line is a really unique service for lots of people, because sometimes hearing yourself use your own voice and say that you're struggling or you're feeling suicidal is a barrier to getting help. And young people especially, they've grown up relating to the world and talking about their deepest feelings virtually through phones and through the computer. And so this text line is a great way that sort of takes away barriers from a person, and is also still really effective in terms of getting people through that time of increased risk, and getting them to the help that would be beneficial for them. The great thing about both of these lines as well is that you don't have to be the one in crisis to be the one who calls or texts. If you are worried about someone, you're worried about a loved one, you forgot all this content, you're not sure what to do, give them a call or text in. And much like 911 can, walk you through delivering a baby if you had to, if you call them, they will be able to both help provide resources and also kind of help you with how to approach the person or how to help in the situation that you're in. So I hope that was enough time to get the number plugged in to your phone. If it wasn't enough time, you can pull down the handout section and open the talk brochure handout. That will also have the Lifeline brochure or the Lifeline number on that brochure as well. So, of course, if if there is an emergency, like a suicide attempt in progress, or someone is making threats or things like that, you don't want to rely on the crisis line. You have to call 911 to dispatch the best emergency services. Now, the suicide prevention lifeline can dispatch emergency services if needed, but if it's an emergency like a suicide attempt in progress, 911 is absolutely the best option there. Together, we can create a culture that's smart about mental health and suicide prevention, because talk does save lives. And so I hope that this short content was helpful. We got about 15 minutes um, to answer questions, and I think that I'll go back to this slide here in a little bit when we're doing questions. I'd love to get your feedback, but I would like to turn it over to RBH and talk about some of the EAP offerings that are available.
Oh, yeah. So the EAP offers free counseling resources for both employees and their family members. It's free and confidential, a 24-hour crisis help, a toll-free access for you or a family member experiencing a crisis. We also offer in-person counseling, and that's face-to-face counseling sessions for work and life issues, other common challenges. And then we have online consultations with licensed counselors at RBH eAccess. And that's available on the new member site at ibhsolutions.com. And you can contact a counselor at the confidential counseling number 866-750-1327.
Excellent. Thank you for sharing that, because like I mentioned before, that seeking help it looks different for everybody, but the EAP is a really amazing option to take away barriers to help, and it's free. So it's also anonymous, right? So if you're worried about being seen at a psychologist's office or something like that, this is a really great place to start when it comes to seeking help, and you don't have to worry about your employer finding out, or have to worry about insurance charges or costs or anything like that. So it's a really, really great service that can help decrease barriers to seeking help. And so I think that is also, this EAP is also, there's a work-life service flyer that you can download in the handouts section. So I'm just going to flip back to this feedback form. We'd love your feedback if you don't mind providing it at that website below. And I don't see, I do see a couple more questions. And it looks like this question might be more appropriate for RBH to answer. I can, looks like I can see the whole thing. It says, any advice if you have an employee that talks with other employees about being suicidal? They have been referred to EAP. Oh, so maybe that's a little bit more for me. Yeah, that can be really troubling for the employees who are talking about it, and I think that within the boundaries of your role as either an HR or a manager, to encourage them to seek help, and that might be, depending on the workplace setting, it might be an appropriate situation to talk to them, to reach out and to have that conversation, and to say, hey, we've been hearing these things. Is everything okay? Or is there anything you want to talk about? And then going back to that slide about listening without judgment, expressing concern and caring, those kinds of things, and then trying to plug them into to resources and to support like the EAP. But that can be a sensitive situation for workplaces, because it could be really troubling to the employees that they talk to. And so I think that that also needs to be handled with care for both the individual as well as the other employees, to not expose them to any unnecessary risk or concerns. And so I don't really have a great answer, but if it's possible, I think that having a conversation, just pulling them in and saying, hey, is everything okay? You've been saying these things and we're worried about you. So is everything all right? That could be an option if the workplace would support that. Oh, I see another question. Where is a good resource for family to research healthy responses to TV and movies glorifying suicide? I don't know if I can pull it up, but we do have the American Foundation for Suicide Prevention does have some resources that we developed uh, along with the American School Counselors Association, along with the American Association of School Psychologists, and they're really resources for parents and things like that. So it looks like I can put I don't know if this will go through. I'm just going to send this link to all, and I think I can pass it along to RBH. But if I just did a quick Google search, my search was AFSP for 13 reasons why. And there's two links. One, there's a whole landing page that has a discussion guide and some videos and some information about that particular show and tips for parents talking with their children about this particular show. But then there's also several other links that we've put together in that can be helpful, because that's a really sort of challenging thing. And I think that while many of the documents that we have there are specific to the 13 reasons why, the discussion guides, the teachable moment webinar, and some of the other things are really can still apply to other TVs and movies that may depict or glorify suicide.
And Brian, I'll be sending out a link with the recorded webinar along with the 2 handouts that we had available. And I can include the link you just emailed. Did you say that you sent it to me as well?
I sent it to all in the questions, but I will email it to you. Yeah.
Okay, great. Thank you.
You're welcome. Someone asked what walk tracker I use. It is a fitness tracker. It's not an Apple Watch, but it's like the sort of poor man's version of it. The brand is Polar, and it's used for mostly running, but it also tracks activity. That's what's been helpful for me. But I know that there may be some benefit that you have purchased into that you might be able to get these, or it might be people might be able to get a discount. But something like that or a Fitbit, it goes a long way for helping me at least. Let's see. I see someone mentioning a question that that they advise if people are feeling suicidal to go to a local mental health and do the 48-hour hold to evaluate. That's a really good option for persons willing to do that. Question about, is the information from the webinar available somewhere? It sounds like we're going to be sending a recording, and much of the content is there in the brochure. And we can also, again, if you would like me to come in person, or one of my colleagues or volunteers that is maybe further away from you, we can find a way to arrange for that as well. It looks like that's all the questions that have come into the bar, and it's a little bit hard for us to read, but I think I got all of the questions answered so far, unless there's any additional ones coming in. I think that we've got them all.
And if we don't get to all of the questions, we can always follow up after the webinar via email if someone's question didn't get answered today. So yeah, that's
Great. Yeah, it does look like that's all the questions I can see in the questions bar. So there's about 80 of us still left here, and just want to thank you so much for your time and attention today. I hope it was a good use of your time. I know this is a question or a challenge that a lot of us in workplaces haven't yet sort of wrestled with. So in addition to this presentation, if any kind of brochures or other information would be helpful, feel free to reach out to us. And I think that my contact information will go out along with the recording of the webinar. So thank you all so much for your time, and hope everyone has a great afternoon.